Another concept, opiate-induced neurotoxicity. All right, so you can make up some bonus points here. Who can give me any symptoms of, or either symptoms of opiate-induced neurotoxicity, or patients who are at increased risk for this?
Kidney failure and
Kidney failure. Okay, very good. Morphine is one of the ones that we see this quite commonly in. Renal failure is a big risk factor. Anyone else want to give me any information about this? Give me bonus points. I know you've heard about this in a couple talks. You've been to my talks, and I bring this up fairly regularly. What are some of the symptoms? What are some of the major symptoms of opiate-induced neurotoxicity? And if you guys can't figure it out, you can look at the title of the talk, and you can probably come up with one of them.
Delirium.
Brilliant! Delirium is one of them. A patient, you need a couple things when you're, as far as I'm thinking about it. I make a clinical diagnosis of this, and if the patient is in the right setting. So this is a patient who's on high doses of opiates or lower dose in renal failure, particularly if they're on certain ones. Morphine and hydromorphone are worse. Actually, this is the whole reason we do not use Demerol. Demerol is the first one this was identified in, but it can happen with any opiate. But Demerol has active metabolite which builds up over time quite dramatically, normoparidine. So do morphine and hydromorphone with their 3 and 6 morphine and hydromorphone glucuronides. Anyway, and those build up over time, especially if someone's kidneys aren't working well. Fentanyl, methadone, and maybe oxycodone seem to do that significantly less. And so there's a lot less issues with that in general on those medications. Generally better choices in renal failure, but it's certainly not impossible on any opiate. And then any two of these three symptoms. One is mental status changes. Delirium, excessive drowsiness, often there'll be some of both. Increasing pain. And here is where we see a really nasty vicious cycle. There's a few of these that we see. You have, someone is on fairly high doses of, they're on, say, a drip of hydromorphone or something. And they start having more pain, and they start pressing the button more, they increase it. Well, that helps for a day or 2 or 3 until those active metabolites build up in their system, and then they're having more pain. So they're pressing it more, increasing the dosage, and pretty soon they're becoming delirious, and you just touch them and they're in pain, and they're jerking like crazy eventually. And I've seen people who probably they've gone up by tenfold on the dose because they keep thinking, well, it does work for a couple days, and well, it's actually they're actually causing the problem, and their pain goes away when you stop the opiate, ironically, or at least you don't stop it cold turkey. But what I do is I first of all watch for it, and then I rotate them. If I am thinking if they're in the right setting and we're finding any of these, two of these things, then I will rotate to methadone typically, and generally try some hydration because you want to flush out some of those metabolites. And again, this is something we need to watch for. If you don't watch for it, we will miss it, and patients can die from this. Patients will die from this because again, they'll get severe delirium, they won't eat and drink, they'll get into renal failure, they'll get worse, and we'll give them a lot of medication, and they will die. And again, I just want to remind you, in this setting, if you, in general, on any patient with either of these things, high dose of opiates or low doses in renal failure, if they have either mental status changes or increasing pain, ask about myoclonus. Is he having muscle jerking? Just sudden muscle jerking. And we're not talking a tremor, we're not talking, shaking, something like that. We're talking just random muscle jerking. It might be just little bits, so it might be quite dramatic. But it's that is key. And if you hear that story, they'll often give you a very, very nice story of yes, we increased. It was just at the same time they increased the opiates, and within a day it was increasing, and then getting more of this. And it's often very clear pattern. So but if you don't ask, you're going to miss it. And you can see it sometimes, but unless you're watching for it, you can easily miss it. We have one person right now with Now, I will remind you that myoclonus is not always caused by this. There are other causes of myoclonus. We have one person down in the house, and she had some delirium, but she also had myoclonus going on for months and months. And it seemed, as best I could guess, that it may have been, when I looked at her medications, the Neurontin may have been a contributor. And so I cut her Neurontin back dramatically, and she's doing a whole lot better. And so there are several medications, including ones we use, including Haldol sometimes, and some others that can cause this. There's actually a long list of things that can cause myoclonus. A lot of people with renal failure will get this in any case. But if they have the opiates and one of those two things, then I think it's worth going presumptively that that is the case. With me on that? Okay. Okay, this does not seem to like me here. All right. So optimizing medications is one of the most important things we need to do. And again, I'm recommending we go through at least this far on every one of our patients, even if we think they're in that dying process. That we're doing the evaluation, we're asking questions, we're using our brains and thinking through what's going on, and we're optimizing their medications. We're simplifying, we're stopping any medications that aren't clearly going to benefit them. Because it's possible that they just have a weird reaction to ibuprofen or who knows what. And so if it's not clearly likely to provide benefit in this period of time, then stop it. And including over-the-counters, herbal medications, things like that. Ask, is there something that they just stopped recently? That might be a clue. Occasionally, you can see that can be with stopping Neurontin and a few and a couple others that can contribute to this. Benzodiazepines, I really find these a major problem. But we don't want to cut them off cold turkey. Now, if someone's just taking once a day, they're just taking at night, then it's my opinion that they won't have a problem with stopping cold turkey because they're already on and off it. Their body is used to being without it half the day. And so if they're not going withdrawal during the day, they're not going to go withdrawal in the night if you stop it. You probably want to give them something else to help sleep, but it's reasonable to stop it, and especially if you're seeing that they may be more confused at night after they get it, well, it's worth stopping. If they're on a schedule throughout the day, I would cut them in half is what I've been doing, and that seems to help, and maybe eventually aim to stopping. If they're on very low dose, you could probably stop it. If they're on half or less, a milligram of most of these. But so cutting in half, if they've just, I would stop all PRN benzos unless you're using it specifically for a treatment of a withdrawal type of symptom in a setting of delirium. If they're confused, I would stop the benzodiazepines that are PRN. Instead, we want PRN Haldol. And this is an issue in the nursing homes because their doctors, the CMS has come down for a couple reasons on the haloperidol. Yes, it can cause sudden death in an extremely rare situation. Yes, it may shorten lives in certain populations, but it's far better option in our population than benzos, in my opinion, especially for PRN. And again, if they're on opiates, especially if there's renal insufficiency or they're on fairly high doses, I would really consider it. Or if their pain isn't well controlled, I'd consider methadone. We've had excellent success with methadone for pain, for good pain control. Okay. So that's optimizing medications. Again, we're thinking about this on everyone, even if we just believe it's part of the dying process. There's no reason to continue things we don't need. Non-medical, and I will say that I've had a lot more patients who've been, since getting rid of a lot of the benzos and cutting back on that and being more aware of this, I've had a lot more patients who've been able to be conversing even the last day of their life or the last couple days of their life and have some nice conversations and most of the time being comfortable and that's obviously ideal. All right, again, an environment is great. If you change environment, they have no idea where they are, that can precipitate a delirium. If it's dark, ears clear, looking in their ears, getting their hearing aids functioning, glasses, making sure they're safe. We don't want them falling and breaking something if they get up and they're confused. Restraints, big problem. We want to minimize these. Unfortunately, when the hospital, what happens, you get all kinds of tubes in people, and you don't want people pulling out those tubes, and so you need to restrain them so they don't pull out the tubes. And so someone wakes up, they have no idea where they are, they realize that they're hurting, and they try to get up, and they realize someone tied them to a bed. Well, they're going to freak out. Okay? It's not a calming thing. If you want to use the least restrictive environment, and minimizing tubes and lines. We sometimes do use like a little, something in their back as far as clysis or sub-Q hydration, but we try to make sure it's as little bothersome as possible, and if possible, want something they won't pull in a place where they won't pull out. Having loved ones close by, or someone just who can reassure them. They wake up, they don't know where they are, someone can say, hey, you're okay, so they're not going to get agitated and get upset. This is just a general thing in dementia and delirium. Some vitamin B deficiencies in particular can contribute to delirium and dementia, and so I think it's good to consider just routine vitamin B replacement. In fact, I'm inclined to think it wouldn't hurt if we just had all of our patients just taking a multivitamin a day. I know they're big on all these different specific vitamins, and vitamin D at X amount, and this and that. I think if we just had most people just taking a multivitamin, even Flintstones, I think we'd be going a long way toward, because a lot of patients are malnourished anyway because they're not taking much. But this is a minor thing, and probably not as much in acute delirium as more of a chronic situation. Unless it's really anyway, there is a syndrome, especially with alcohol problems, where they can get into crisis from B6, but we won't go there. Common reversible causes. Again, thinking through this, at least in all of our patients. These are just a review of what we just talked about, the key things we want to think about. Bowels, bladder, infection, especially UTI, liver, pneumonia. Sometimes lactulose can really make a difference with that. Hypoxia, sometimes putting O2 on someone will clear it up. Dehydration. Sometimes I probably should put on glucose on there, especially if someone has known glucose problems. That can contribute to some of this. Dehydration. Again, the dehydration can cause delirium. It also can be caused by delirium. And so what you can get is you get delirium from another cause, and they don't eat and drink, and then they get dehydrated, and may get electrolyte disturbances and all kinds of other things, and that worsens their delirium. And by the time you fix the original cause, they may be delirious because they're so severely dehydrated. And again, all untreated delirium is terminal delirium. All delirium is terminal delirium unless it is treated. And so, assuming it is that, again, it depends on the trajectory and the path and what the deal is. But